Hello everybody, my name is Mark Johnston. I'm the Program Coordinator at the Burn Center at Regents Hospital in St. Paul. Today I just wanted to quickly run through the ABCs in initial burn care. There are much more details that I can provide to these points for this video. I just wanted to highlight a few things to keep in mind when caring for a burn patient. Management of a burn patient really should be the same way you manage any other patient, the ABCs. Burn patients often suffer associated injuries in addition to the burn injury, and you have to remember to treat those problems also. When assessing the airway, we really want to know how the burn occurred. Any burns that were suffered in an enclosed space, burns to the face and neck where the patient was unconscious, and burns with blistering about the face should give you a high suspicion of an airway or inhalation injuries. Patients with soot in their hypopharynx also should be assumed to have an airway or inhalation injury. It is not always easy to tell if an airway has been burned, so if you suspect that it has, intubate early. Don't wait until the patient becomes unresponsive or develops a hoarse voice or stridor, as these are late signs of an inhalation injury. In addition to the inhalation injury, the patient could have also inhaled smoke. The B for breathing should remind us to put the patient on oxygen. Besides smoke, the patient could have also inhaled other byproducts of combustion, such as carbon monoxide or hydrogen cyanide. Being able to check a carbon monoxide level early is helpful in determining the level of injury. These patients should be placed on 100% oxygen, and keep in mind that pulse oximeters should not guide your oxygen use. They are not useful in the presence of carbon monoxide. The C for circulation should remind us that burn patients can be at great risk for hypovolemic shock. Patients that suffer a greater than 20% total body surface area burn will develop a systemic capillary leak and will need IV fluid resuscitation. IV access needs to be established early and maintained. IV fluid rates initially should be established at 500 cc's per hour for adults, 250 cc's per hour for children, and 125 cc's per hour for small children and infants. A more specific fluid resuscitation rate will be provided by the burn surgeon at the burn center when contact is made. If the patient has a Foley catheter in place and urine output can be monitored, we would be targeting a range of 0.5 cc's per kilo per hour. If a Foley catheter is not in place, one should be considered. Burn patients also are at a great risk for hypothermia. Active warming measures should be instituted. Dressings do not need to be placed on the burn areas, as many of these can become difficult to remove upon arrival to the burn center, and also will contribute to hypothermia. Our recommendation is to cover the patient with a clean sheet and warm blankets. I stated earlier, this is a quick overview of the initial ABCs of burn care. Much more detailed information can be provided by emailing me at mark.j.johnston@healthpartners.com. Thank you.